Good. I would like to welcome everyone to the University of Texas MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for October 2nd, 2020. I think we have a very exciting conference for you today, the best way to start your weekend. And I subtitle this conference, Adventures in Neuro-Oncologic Diagnostic Medicine. Okay, I have one very important announcement to start with. The upcoming IDMCCs, it was going to be October 16 and 30. It may still be, but here it is in a nutshell. One of my colleagues in the section of neuropathology has unexpectedly retired 3 months early. Therefore, all of that call goes to me. And for about the next 4 straight weeks, I will have no time off, which means I never give the conference when I'm on service because of frozen sections. I can't control that. What it means is the conference time and maybe the day will have to change for me to keep doing it. It's either going to have to be really early in the morning before early morning conferences, 7 a.m. Neurosurgery conferences start, and of course the frozens, or it may have to go to the weekend, which would be Saturday or Sunday. Saturday morning's a terrible time because I know the neurosurgery residents, neuro-oncology, everyone makes rounds, etc. It might go to either early Sunday morning or Sunday evening. I am not sure, or it'll go early, but I want to continue doing the conference. We will get through this. We will recruit another faculty member as soon as we can, but that could take a while because of the the COVID-related finances, et cetera, et cetera. Okay, so stay tuned. When the day and timer is set, I will send out an email to everyone on the invitation list and let you know what the status is. Furthermore, when the recordings are successful, for those of you who are unable to attend to the new meeting time and all of that, I will send you a link to the recording, right? So you won't miss out. Okay, without further ado, let's get going. MRI warm-up. We always do warm-ups. Here it is. I've got the chat function going. So if anyone would like to make differential diagnosis, Andrea Gilbert says ependymoma. I like that. Could you be? Yeah, I mean that's fine. We're gonna wade in a little bit deeper. Okay, okay. Ricardo Rivera Fernandez says what she said. I love that. That's perfect. Okay, for those, I know we may have some attendees that are not familiar with neuroimaging. So I've circled the lesion. Essentially, what we're seeing here is a circumscribed enhancing mass in the caudal fourth ventricle extending into the cisterna magna through the median foramen of Magendie. That is classic behavior of posterior fossa fourth ventricle ependymomas. They like to grow out plastically, fluidly through the lateral outlets of Luschka and the median foramen of Magendie. Ependymoma has to be number 1 on your list for this tumor. And we'll just leave it at that for the differential diagnosis. Now, how about the histology? Let's have a look at the histology and low power. And immediately you can see some congested blood vessels. You see dense, nuclear dense areas and pale fibrillary areas. And I think it's pretty obvious. These are classic perivascular pseudorosettes. And that's just, and there's one giant, giant perivascular pseudorosette, very fibrillary, uniform, regular, round to oval nuclei with delicate stippled chromatin pattern. Everything fits from the imaging, from the behavior of the tumor, not just anatomic location of the tumor on the imaging, to the histologic features. Now, here comes the question. With the World Health Organization CNS 5th edition, forthcoming 2020, what is the diagnosis? At this point, for all of the information that you have, what is your diagnosis? What would go on your report in the diagnosis field? I'll give you a hint. It's not just ependymoma. That's wrong. You get an F if you said ependymoma. All right. The answer is posterior fossa ependymoma. If you didn't put the posterior fossa in there, then you are hopelessly behind. You're still in the WHO 2016 classification. We go by anatomic region first, then ependymoma, then It has to be either one of the two molecular signatures, PFA or PFB. And if you do not have that data, which I have not given that to you, then it has to be NOS, not otherwise specified, which means that you do not have the data to more specifically classify it. All right. Okay. Question. What do we need in order to render a more precise diagnosis than not otherwise specified? A more precise diagnosis that would help. Oh, Andrew Gilbert, all over it. Yes. And Zainab Harb, definitely. H3K27ME3. Yes, yes, yes. This is what you need. It's a simple, listen, it is a simple, commercially available, robust, reliable antibody, 24-hour turnaround. Now, if you're in a community hospital, you don't have it, you can outsource it. You'll have it, you'll have it within 48, 72 hours, well before the patient would need to be treated, because for any treatment, whether it's going to be radiation, chemotherapy, et cetera, it's always going to be 10 days minimum in order to allow healing, of the brain, the tissues, meninges, all of that stuff. So plenty of time to do that, super easy. Now, this is the point, all right, critical immunostain for posterior fossa ependymoma H3K27ME3. Let's run through it quickly. This is from the C-Impact Now Update 6. Everyone in this conference should be familiar by now with the 7 C-Impact Now Update papers, which presage the forthcoming WHO 2020. All right, here it is. Posterior fossa ependymoma, pediatric type, or PFA, proposed definition. A posterior fossa ependymoma that has a PFA DNA methylation profile or, let's emphasize or immunohistochemical loss of nuclear H3K27ME3 expression. So you do not have to have access to the very sophisticated esoteric technique of DNA methylation profiling. All you need is an immunohistochemical laboratory in the antibody, or you can outsource it super easy. All right. Many places, many commercial laboratories will run this for you. All right. So with a posterior fossa ependymoma, all you need to do is run the antibody. If there's loss of expression, it's PFA. If there is retained expression, expression of the trimethylation mark, ME3 is the trimethylation mark, then it's PFB. It is as simple as that. One antibody will differentiate PFA from PFB. Everybody got that? And this will be, the definition will be included in the WHO 2020. So that's very exciting. All right, let's review this very quickly. Ependymoma classification in the forthcoming WHO 2020 classification. Posterior fossa ependymoma, pediatric type or PFA, adult type or PFB, because those are predominant. We say adult type, pediatric type, because it's not, there are exceptions. The Gaussian distributions overlap, but predominant types, PFA in children, PFB in adults, and then you have to use NOS, not otherwise specified, if you have no molecular data, and NEC if you do have the data. You did run the H3K27ME3, or maybe you got methylation profiling, maybe you ran next generation sequencing, and you turned up a molecular alteration, all right, with a significant mutation, fusion, et cetera, but it was not of the type that would allow classification as PFA or PFB, then you could call it NEC, not elsewhere classified. It means you do have molecular data, but it doesn't place it in either the PFA or PFAB group. Again, this is what loss of trimethylation mark looks like. You can see the normal internal positive control, the endothelial cells staining strongly brown, and the blue hematoxylin counter stain in the tumor. This is an example of a posterior fossa ependymoma group PFA. Now, our tumor, I do not have the immuno to show you. All of the nuclei strongly brown in the particular tumor we're looking at in this adult patient, and that puts it at, that means retained trimethylation mark, which means posterior fossa ependymoma group PFB. You like that? There it is. All right, C-Impact Update now 7. Here's the classification table, which will be the same as in the forthcoming WHO 2020. We classify ependymomas first by anatomical location: supratentorial, posterior fossa, spinal, and then subependymoma can be in any of those 3 compartments, right? Can be in lateral ventricles, can be fourth ventricle, can be in the spinal cord. Therefore, it has its own little separate classification. Then for supratentorial ependymoma, there are two molecular signature defined entities: C11orf95 fusion positive and YAP1 fusion positive. All right. C11orf95, we used to call REL-A fusion positive, REL-A fusion positive. We're using C11orf95. That's a more reliable fusion partner. The most common fusion partner is REL-A, but this is going to be the name. You should know that. All right, for posterior fossa, group PFA, PFB, we just talked about. And then for spinal, MIC-N amplified, more aggressive clinical behavior. That's why we separated out just one molecular signature. The other big update here, myxopapillary ependymoma, which previously has always been classified as a grade 1 since the inception of the World Health Organization classification system, will now go to grade 2 because all of the clinical trials, all the clinical data, and personal experience at all major medical centers in the world show that its behavior is closer to a 2. So we're going to move it to a 2. All right, now question. There have to be some of you that are thinking, what is the point in showing yet another ependymoma in the IDMCC? We just saw one 3 weeks ago, not this case. Every case that I show you in these conferences, probably forever, however long this conference goes, they will all be unique. They will all be new. There's another example. We just saw one 3 weeks ago. You're complaining. Am I correct? Well, look, here's the point. Listen, this is the point of the exercise. All right. When you saw this image, one of the first things that should have popped into your mind involuntarily, because it's second nature, is H3K27ME3, because you would have immediately seen that high in your differential was posterior fossa, was an ependymoma, and the critical image was H3K27ME3. Now, if that did not happen, if you looked at this and your brain stopped at ependymoma, that is why I'm showing this case. You are not yet ready to stop seeing posterior fossa ependymomas unless one of the first things you think of is H3K27ME3, run the antibody, and you see the whole thing laid out. Everybody got that? And that goes for all of the other molecularly defined ependymomas, and that's why we do it. We're not going to take a lot of time, but it will keep coming up, all right? Now, I'll have to say, that we do have people, like Dr. Gilbert and Dr. Harb, who that was their first thought, H3K27. Okay, that's fantastic, all right? But I want the entire group, everyone listening, attending, whether you are neuroradiologist, body radiologist, general pathologist, or neuropathology fellow, to be on the same plane. We need to speak the same language, okay? All right, hey, this is something new. I decided, we always do, we'll do like an MRI warm-up, a CT warm-up, a genomic signature warm-up. How about let's do a neuro-oncology warm-up? We haven't done that before. Does that sound like fun? Okay, you ready? All right, here's gonna be the question. The neuro-oncology question is, which chemotherapeutic agent was given to the patient whose image I'm about to show you? Okay, you ready? You got the chat function going? Everyone ready? It's gonna be quick. I want a quick answer. Which chemotherapeutic agent did this patient receive? Here we go. I see temozolomide. Wrong. Waiting. I see the name of a product, wafer. Wrong. A wafer is not a chemotherapeutic agent. Okay, Dr. Hunter, very good. Rapamycin, no. BCNU. Octavio, okay, listen to this. This is Octavio Areola, the neuroradiology fellow, oncologic neuroradiology fellow at MD Anderson Cancer Center, just nailed this one, BCNU. It's BCNU. Now, these are gliadel wafers, as Dr. Gilbert correctly identified, but I didn't ask what type of wafer was it. I asked what was the chemotherapeutic agent, and gliadel wafers are impregnated with BCNU. They do a slow time release. Everybody got that? Was that fun? Yeah, that was fun. All right, maybe new knowledge if you didn't know that. BCNU is time-honored treatment for all sorts of high-grade gliomas, gliomas in general. Okay, look at this. I have a gross photo of that wad of wafers. This is it. This is a gross photo. Isn't it cool that I can actually show you the surgical pathology specimen from that case? How cool is that? The only reason why I can show you this photo is because I took the time when I was grossing in the specimen to call medical photography, and that's how you generate photos like this. Now, I guess you could use your iPhone. Questionable ethics, yeah, I got that totally, right? Probably recommend not against it, and it's gonna look horrible. Or I could have photographed it on a bloody green surgical towel. Man, that would have been nice, wouldn't it? But look at this. This is magnificent. The black background, the detail, that was done by the MD Anderson Cancer Center Medical Photography Department, all right? Trained professionals, exquisite. But it's also dependent on the pathologist taking the time to get the photo. And you can do this even there's a frozen section. We've talked about this many times before. You can still get a frozen section. You just take it from a side, the back, an edge, whatever, do your smear, do the frozen section, get all that going while you've called medical photography, et cetera. Now, I know many people, pathology, you may not have medical photography unit, but you probably have some mechanism, right? Way of doing it. It's worth the time because gross photos are worth so much. All right, so there you go. Let me ask you, okay, let me ask a follow-up question. Here's the follow-up question. Follow-up question is, what do you think about this? Is that the way the neurosurgeons, when they put in the wafers, when they place the wafers, is this some sort of gelatin or whatever that they grab a bunch of them, wad them all up in a ball and embed them in the tumor? Of course not. How it happens is typically they will be put at the time of resection. It'll be a resection. There will be a post-resection cavity, and they line the wall of the cavity sort of equally spaced with the wafers, and then they place hemostatic agent over that, which will adhere to the cavity wall and ideally, theoretically, hold the wafers up against the wall where they will slowly infuse over time release, brachy chemotherapy, if you will, the chemotherapeutic agent into the walls of the cavity, because we know that the number one by far site of initial recurrence of diffuse gliomas is local at the wall, all right, adjacent to the wall resection cavity. There are other mechanisms, CSF, dissemination, et cetera, but by far that's a theory. What tends to happen in many cases, however, is that the surgical cavity collapses. It ultimately can collapse, and then you end up with a wad here in the center. It doesn't mean it's not releasing chemotherapeutic agents. Also, this does say something else, and basically what it says is ultimately there's benefit, but failure, and then it becomes a surgical specimen. Okay, you like that? Okay, let's move on. Let's do an MRI warm-up. Okay, number two, sorry, MRI warm-up number two. Here we go. All right, differential diagnosis. Differential diagnosis. Okay, I'm watching the chat. I am not going to move forward till someone. Now, I'm going to. You can give a differential, this sort of thing. All right, Octavio nailed it. I'm going to hold off. Dr. Sanjay Singh, Senior Don Neuroradiologist, Texas Medical Center, also nailed it. Pedro Diaz Marchand, also Senior Don of the Texas Medical Center Neuroradiology, also got it. Man, it looks like all of the neuroradiologists are all over it, okay? Ricardo Rivera Fernandez, yes, absolutely. Well, tumefactive, yeah, that's it. All right, good. Is everyone impressed? Listen, this is pretty cool. This is pretty cool. At least 4 people nailed this. They didn't even think about it. If you're a pathologist, neuropathologist, wouldn't you want to have the power of these people? Well, why don't you have the power? Is it because you say, I'm not a radiologist, not a neuroradiologist, I can't look at scans, I can read a report, or I can listen to whatever the surgeon tells me? Come on, why would you not want to have the power that the neuroradiologist has? Just simple things. They know extremely complex stuff, pre-surgical planning. I mean, all of this thing, way beyond us as pathologists. But we're anatomists, we're morphologists. Come on. You need to see pathology and imaging. Yeah. All right. Bottom line is this is giant tumefactive perivascular vertical Roban spaces. It is not a tumor. It is not scary. It's static. It is a Ann Osborne, leave me alone lesion. Unfortunately, we tend not to leave them alone. All right, let's look just quickly at the literature. Andrew Gilbert, I'm going to address what you just said in just a second. Giant tumefactive perivascular spaces, and there's the great Ann Osborne there, Osborne's brain. And guess who Roy O. Weller is at the end there? All right, a British neuropathologist. Yes, neuropathologist. Look at that. How do you like that for dilated perivascular spaces? Does that look scary, freaky, or what? That's dilated perivascular spaces. Extreme example. All right, here we go. Giant tumefactive perivascular spaces mimicking a brain mat. Now that is the problem. The problem is when you don't know, you don't recognize it, you don't consider it as a possibility and look for evidence, look for data that would support your hypothesis. If you don't know about it, you can't think about it, you could hurt your patient. All right. So look at this. You can see here examples of one they're giving that could mimic a cystic brain tumor. That was the point. Here we go. British Journal of Neurosurgery, neurosurgical image, dilated Virchow-Robin space in the brainstem. It's not just the cerebrum or then the basal ganglia, brainstem. Look at this. Look at that pons. That is impressive, is it not? All right. Mesencephalon, midbrain. Yeah. Here we go. Dilated Virchow-Robin space, a 6-year-old boy. Check that out. Now, you know what we're doing here? What we're actually doing in showing these images from all of these papers, we are presenting the spectrum of dilated perivascular Virchow-Robin spaces. But we're only showing, listen, we're only showing so far the extreme end of the spectrum in terms of size and number. We're going to go the other way in just a second and address Dr. Andrea Gilbert's comment. Okay, Dr. Sanjay Singh says diffusion weighted imaging helps. Thank you, Dr. Singh. Absolutely, and that's going to be my upgrade to this this entity the next time I present one. Thank you very much, Dr. Singh. All right, how about this? Giant tumor factor perivascular spaces manifesting as chorea bilaterally. Ooh, check that out. Now I will tell you that the basal ganglia are the single most common site, probably more common than the cerebrum, extremely common, especially for the minor form. But look at that. That is impressive. Okay, Dr. Gilbert said, shouldn't we talk about état criblé? Yes, of course we should. So in honor of Dr. Gilbert's comment, I have included, I just put it together last few seconds here. I am that good. This series, what do we got here? 1, 2, 3, 4, 5, 6, 7 different MD Anderson Cancer Center patients showing the spectrum of état criblé. And let's see, here we go. This is for those who may not be familiar with neuroanatomy and basal ganglia. I have circled bilaterally, or maybe unilaterally in one case, the dilated perivascular spaces. Now, when they are small and multiple, we call that état criblé. And you can see the top right row to the far right. That's kind of that's the high end. Now that patient is like one step away. If all those things start dilating, right, then we end up with the case that I just showed you with the chorea, right? Because of the really big ones. Now in the bottom row, you see now that's where they're enlarging and they can mimic tumors, but it's exactly the same phenomenon. And that's why I've chosen the basal ganglia for all of these 7 patients. Now look at that. Now you have seen, probably for the first time assembled this way, the full spectrum of dilated perivascular spaces. At the low, small, we'll say small end of the spectrum is what we have traditionally historically called état criblé. At the high end of the specimen in terms of size, it's called giant tumefactive perivascular spaces, but it is the same physiologic process. You like that? Isn't that just fascinating? I'm just giving you one more look at the slides, so you can look at the small ones there in the basal ganglia and the lenticular nucleus, and just appreciate them. Burn that into your brain. Got it? Okay, we need to look at the États very quickly. This is a list assembled by Joelle Peterson. She's now a neuropathologist. This is back when she was neuropathology fellow, and Roy Mayer was a neurosurgery fellow, I believe at the time. État lacunaire, status lacunaris, multiple lacunar infarcts, usually basal ganglia. État criblé, we just talked about. État glacé, cerebellar conglutination, postmortem artifact. État marbré, status marmoratus, increased white matter basal ganglia, thalamus following hypoxic injury in a fetus. État spongiosis, many different etiologies of that. État fibrosis, or gliosis corpus striatum related to Huntington chorea. État dysmyelinique, progressive degeneration fibers to striatum globus pallidus. See how frequently the basal ganglia figure in the États. Okay, angiomatose, status angiomatosis, referenced in books from the 1800s, all in French. Okay, here you go. I'll give you some sort of prize if someone wants to research it. I know we got to have a lot of French speakers. Go back, check these things out and let me know exactly what I think I did it way back at the time, and I've totally forgotten. We don't use it. So you're getting all the états here. We don't talk about music. Okay, personal favorite, the last, of course, état de fromage de gruyere. This is cheese. This is an exquisite cheese. Yes, cerebral porosis, porencephaly, Swiss cheese artifact. It can also be the postmortem gas-forming bacteria, Clostridium, etc. Okay, very good. Okay, let's move on. We have done this before, so I'm not calling it a new conference feature. It's what's wrong with this picture. All right, everybody ready? Okay, I'm going to be watching the chat function. What's wrong with this picture? Watching the chat, watching the chat. There's something wrong here. There's something that could be misleading to you if you're not a neuroradiologist. Yes, Pedro Diaz Marchand, neuroradiologist. Yes, 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 yes. Good job. Good job. Good job. Okay. What is wrong with the picture is it's not a T1. This says it's an axial T1. All right. This is a T2 flare, right? Yes. Okay. That's it. Now, what is the point? The point of this, it's an example. Listen, it's principles we deal with. Principles. This is an example of an error in the medical record, and the errors are everywhere. They're in the clinic notes, in the H&P. Everywhere, the medical record is full of errors, and if you are gullible and you just believe what you read in a clinic note, in a report, in a pathology report, in a radiology report, then you're going to have a tough time if you're that gullible. You need to develop the skills to analyze the data for yourself. Trust no one. These are frequently mislabeled. It's a human data entry layer, especially those coming in from the outside films all the time. Yeah. Okay. Was that fun? Did you like that? Yeah. It's T2 flare. Good. I think I enjoyed it. But again, it's the principle, right? Okay. Yes. Okay. Dr. Vince Kumar says, from the prior discussion, lacunar infarcts will have a rim of flare abnormality. Perivascular spaces will not. Everybody got that difference between état lacunaire and état criblé? État lacunaire, rim of flare. Thank you very much, Dr. Kumar. All right. Dr. Vince Kumar is our preeminent neuroradiologist, is an expert in ABTI and functional brain imaging at MD Anderson Cancer Center. Okay, you know what? I think we're warmed up. I think we're warmed up enough for patient one. So let's do it. 24-year-old female. We're going to start with the histology on this. Low power. I'm trying to mimic as much as possible having the actual glass slides or whole slide imaging you can manipulate. Let's go a little bit higher, a little more detail. All right. That's it. Anybody have an idea? Any thoughts? Based on the H&E, can you formulate differential diagnosis? Dr. Zainab Harb, yes, oligodendroglioma. Look, if you don't say oligodendroglioma as your differential for this, there's something wrong with you. As high on your list, this is classic oligodendroglial morphology, regular, round, monotonous nuclei with surrounded by this hydropic swelling of the cytoplasm, an artifact of FFPE, formalin fixed, paraffin embedded tissue, so-called perinuclear halos, diffusely infiltrating the background neuropil. Absolutely. Could there be other things? Well, central neurocytoma, if it was in the ventricle, would be one. Clear cell ependymoma. Could it be a plenty? Yes. Thank you, Dr. Gilbert. Absolutely. All right. Guess what? Have a look at this. This is the IDH1 R132H. This is an antibody. It's actually anti-IDH1 R132H protein. So it's an antibody directed against the canonical mutant, most common mutant of IDH1. And you can see it's every single cell. That's one of the wonderful things about this antibody and about the molecule as a marker for IDH mutant diffuse gliomas. Virtually 100% of the cells will express it. And you can identify diffusely infiltrating cells far and wide using this antibody. Once you have it set up and working, it really is magnificent. It's been so much help. Okay, here's the bottom line. Let's go back. Let's go one edition before the WHO 2016. That would be the 4th edition. The WHO 2016 was the revised 4th edition, and we usually call it the WHO 2016. The WHO 2000 was the 4th edition, so we call it WHO 2000. Now, WHO 2000, H&D, listen, H&D was the bottom line, the gold standard. Molecular signature was a footnote, an addendum. It did not determine the diagnosis. all the way up to 2000, right? So under the WHO 2000, the diagnosis for this tumor is oligodendroglioma, WHO grade 2. See the Roman numerals, that also places it right back at 2020 and 2016, because the HED says it is. We know it's a diffuse glioma because we can see it infiltrating the neuropil. Classic features, done and done, right? This tumor is not an oligodendroglioma WHO grade 2 under the forthcoming CNS-5E 2020, all right? It is an astrocytoma, IDH mutant, WHO grade 2. Why? Why? Because FISH showed deletion of 19q only with 1p intact, therefore negative for 1p19 co-deletion, therefore astrocytoma, not oligodendroglioma. So look at this, just think about it for a second. Under the WHO 2000, we would have known, listen, we would have known that there was 1p19q co-deletion of this tumor in 2000. We still would have called it an oligodendroglioma because it was accepted, listen, it was accepted in 2000 that 10, 15% of oligodendrogliomas, all right, would not have 1p19q co-deletion, right? And you could study them, subset them with 1p only, and you could narrow it to the minimally deleted region and look for oncogenes, this sort of thing, right? But in 2020, we have moved beyond that because we have to do the molecular. Now listen, here's the point. Here's another major point. Think about it. I think everyone knows this because we said it. Classical oligodendroglial morphology, like the present case, has approximately 85, maybe 90%. If you keep it really pure, it means really regularly monotonous, with no exceptions of a scattered bizarre cell here and there, really monotonous, really round, perinuclear halos, classic. It's got probably about a 90%, honestly, positive predictive value for oligodendroglioma. I said that says oligodendroglioma, apologize for that. I'm going to ding myself for that spelling error. IDH mutant and 1p19q, but co-deleted. But listen, it was only going to work for those of you who are mathematically gifted. 85 to 90% is not 100. They actually are not the same. All right. Now we say this a lot. We say that 85, 90%, it's going to be predictive, and that means 10 to 15% won't. But do you really believe it? I'm talking to the pathologist here. Do you really believe it? Well, you just saw a case. Yes, it's a small percentage. I don't even know if it's 10%, honestly, that are truly classic. And we're going to throw those out. They're no longer going to be classic. If there are scattered here and there a really large atypical bizarre nucleus, you see these, then that is not classic anymore. You already got that? Yeah, it's not 100%. All right. 10 to 15%, let's call it 10% of classical histologic oligos are molecular astros. Now that should send a chill down the spine of every neuropathologist that doesn't really believe it, and for every neuropathology fellow that doesn't really believe it. Now the good news is 90% of the time you will be right, but 10%, that's why we require the molecular signature. Now I have an interesting follow-up. Are you already ahead of me on this one? You should be. Could this misdiagnosis have been prevented? Could it? Yeah, easy breezy. Absolutely, no problem at all. Giant red flag says, no, it's not oligo. It's not a red flag. It says not oligo. What is it? Yes, Dr. Harb, the preoperative imaging, okay? Dr. Lopez, Giselle Lopez, I like your IETRX. It's even easier than that. You don't even have to spend the money or run it. Look, here we go. How? That's a T2 flare mismatch. When it's present, it's 100% positive predictive value for astrocytoma, IDH mutant. 100% positive predictive value when it's this classic, huh? All right, imaging. All right, when present, T2 flare mismatch, 100%. Now, listen, it's not going to help. Okay, but here's the thing. Now, question. Let me ask another follow-up question. I'm going to do some public shaming. Yeah, I'm going to have to tell you about who made this misdiagnosis. And I usually don't do this, but in this particular case, I will because it was me. I did this. How could that have happened? Well, it couldn't. It couldn't today. But you know what? In 2015, I didn't add that to the history, did I? This is a 24-year-old female patient in 2015, 2017. is when the T2 flare mismatch sign came on board. We didn't know about it. We didn't have it in 2015. We do now. This was ultimately corrected. You know how it was corrected? It was corrected because we did not have the molecular data. It was really oligodendroglioma NOS, if you will, the original diagnosis 2015. Once the data came in, 1p19q co-deleted, then that's it, done and done. The IDH mutation we already had, yeah, absolutely. So it was corrected, all right, not long, afterwards. But look, we do know, listen, pathologists, we do now know about the T2 flare mismatch. Incorporate it into your practice. I'm talking to the pathologist, the neuroradiologist already all over this. All right, examining the preoperative MR imaging studies for the presence of the T2 flare mismatch sign cannot prevent all misdiagnoses of IDH mutant diffuse astrocytoma that mimic oligodendroglioma because it's not always present. And the negative predictive value is very, very poor. We'll call it non-contributory. It means if the T2 flare mismatch sign is not present, it still could be mutant astro, or it could be oligo, or it could be wild type astro. It could be anything. Understand? But when it's present, it serves as a strong red flag militating against oligodendroglioma. In fact, it's more than that. It actually says it's astrocytoma IDH mutant. All right. And then, of course, we still have to grade it, look for mitotic figures, but that's honestly, that's minor and in terms of prognosis. All right. And we still, of course, have to run IDH. We have to look at 1p19q, ATRX, P53, look for the classic triad. Absolutely, we will do that. But why would you ignore the pre-op imaging? Yeah, you like it? That's the whole point. Listen, if you're a surgical pathologist, that's the whole point of integrative diagnostic medicine. That's the whole point of this conference. Integration. Integrating what? Integrating the 8 data spheres: age, gender, clinical history, anatomical location, imaging characteristics, histology, differentiation marker, enemy phenotype, and molecular signature, and the convergence of that data. The convergence of these 8 data spheres 99 times out of 100, 999 out of 1,000 will give you a precise diagnosis. And equally important to giving you a precise diagnosis, it will give you an accurate, a true precise diagnosis, not a misdiagnosis because of a mimic, right? And we said this many times before, any given tumor can mimic another tumor in virtually any one of these data spheres. The histology, molecular signature, yes, absolutely. Age can be, yes, absolutely, but not in all 8. That would be exceptionally rare. All right, now here's what happened in this case. Let's look at this case we just talked about. We only had 6 data spheres. We only had 6 data spheres in 2015. We had the age. Now I put the age in red because actually 25 years fits really, really well with diffuse astrocytoma, not oligo. I mean, they overlap, but usually oligo, we think over 30. That's going to be the most common age of presentation. This is the big sweet spot of the Gaussian distribution. Okay, but that's okay. Female, fine. Seizure presentation, very good for diffuse glioma. Frontal lobe, very good. Most common location of IDH mutant disease, including oligodendroglioma, as well as IDH mutant diffuse astrocytoma. And then differentiation markers, S100 positive, GFAP positive, OLIG2 positive. OLIG2 is a marker for diffuse gliomas, astrocytoma and oligodendroglioma, usually negative in ependymomas, which do not diffusely infiltrate. And the histology, that's histology there, oligodendroglioma. So very appropriately, oligodendroglioma NOS, based on the 6 data spheres that we had at the time in 2015. Let's add 2 more. Oh, okay, well, look what happens here. Now we know that there's a T2 flare mismatch and IDH mutant, that should be, 19q deleted, IDH mutant 19q deleted, 1p intact. In other words, negative. I should have just put negative for 1p19q co-deletion. All right, and there you go. Astrocytoma IDH mutant, done and done. Now this emphasizes the safety net function of having all 8 data spheres. You do everything you can to get all of the data. The 2 critical pieces that often are missing being molecular signature and pre-operative imaging. Here's the point. Let's say at your institution, new patient comes in, you have the histology, you need to move mountains to get the preoperative imaging. If you were talking about a diffuse glioma, non-enhancing diffuse glioma, move mountains to get the imaging. Next best thing is the report, but the report is often inadequate. The report will often say, especially general radiology, community hospital, will say T2 flare, hyperintense lesion. Doesn't say anything about the central suppression with a hyperintense rim or T2 flare mismatch. That's still largely confined to our world, the neuro-oncology world. You have to protect your patient. Pathologist, it's your responsibility to protect your patient. This is critical knowledge, right? Yeah, this is all fun stuff. And listen, if I sound like I'm lecturing, believe me, I am lecturing myself because, it's like, to err is human, we all do it, and we all need the reminder. All right, so there it is, the 8 data spheres, a great model. Okay, let's move on. Let's go to patient number 2. Okay, 32-year-old male. I'm going to give you a second to have a look at this. Okay, and then for those, here we go, who may not be as familiar with imaging, T2 on the far left, T2 flare, fluid attenuation, inversion, recovery, suppresses normal water signature, and T2 with contrast. All right. Now I'm going to give you a little bit more. All right. Kristen Huntoon, low-grade glioma. I like it. Zainab Harb, diffuse glioma. Diffuse glioma a little bit better than low-grade glioma. Do you know why? You know why, Kristen? Because low-grade glioma includes pilocytic astrocytoma. That's a grade 1. Subependymal giant cell astrocytoma. That's also a low-grade glioma, as you see. So diffuse glioma is a little more precise. Okay, let me give you a little bit more. Let me give you a little more data. There we go. Let's look at the MRS, magnetic resonance spectroscopy, or proton magnetic resonance spectroscopy. If you're at a cocktail party, it's the difference between medulla and medulla oblongata. All right, now you can see here, for those not familiar, what I've done in the upper panel, the little yellow highlight box in the upper with the red arrow, that's where this is multi-voxel MRS, and you can see the voxel is in the contralateral normal gray matter. You can see how superficial it is, contralateral cortex, or it's including cortex, and what you see is the beautiful Hunter's angle, like a 45-degree angle going up. Up is good from choline, creatine, NAA, all right, N-acetyl aspartate. All right, choline is a marker of cell membrane turnover. It's a marker of cellularity. Creatine is an energy metabolite. How active is the tumor? And NAA related to neurotransmitters, related to neurons, cell bodies, and axons. Up is good. That's what it looks like in the cortex. This, as you can see, the voxel here, I'll highlight it. This is the white matter, normal white matter. You see it's moved more towards the centrum semiovaly. You can see there's been a decrease in the creatine, increase in choline membrane, that's the myelin sheath, decrease in creatine, maybe white matter not as active as gray matter, and the NAA still high. Up is good, normal. All right, now let's put the voxel in the tumor. All right, look what has happened. What has happened to the slope of the choline creatine NAA? All right, there's a voxel in the tumor. Well, it's flattened. It's actually reversed a little bit. Okay, what does that say? Well, what it says is, number 1, not normal. Number 2, it is inverted slightly, which is going to favor glioma, but not high grade. High grade glioma is going to be densely cellular, and the neurons, the axons, are going to be squeezed out. They're going to die. And so the NAA, which is related to the neuronal function, is going to go way down, right? And you're going to have a steep inversion of Hunter's angle, right? Down is bad. So you put it all together, what does it say? You put the two together, it says low-grade glioma. Now, we already were thinking low grade meaning lower grade, not low grade, but lower grade. Lower means 2 and 3. 3 is anaplastic oligo, anaplastic astrocytoma. Now, we used to consider, I think many people, anaplastic as being high grade along with glioblastoma, but not anymore, because we know that the 2 and 3s cluster really tightly together, and it's typically IDH mutant disease, and it is very distinct, very sharply separated from IDH wild type disease, i.e. glioblastoma, which is grade 4, right? So what this says, actually, what this curve says, if you put the non-enhancing T2 flare, hyperintense, infiltrating the cortical ribbon, right? So not vasogenic edema only, going into the cortical ribbon, it says lower grade. that's lower, grade 2 and 3, and the MRS is going to favor a 2. If it was steep, it would favor high cellularity, dense cellularity, which usually will be accompanied by increased mitotic activity in the context of a diffuse glioma, and therefore grade 3, right? Mitotic activity being one of the determining factors. Everybody got that? How powerful is this? Now, look, you're looking at all of this. All of this is available to the pathologist before surgery. Why would you not want to know that, and to that degree of precision? Okay, one more. How about some advanced brain tumor imaging? And I put this in especially for Dr. Vince Kumar, our expert, all right? And what you can see is, this is the AS arterial spin labeled for blood flow, and sure enough, there's elevated flow in the tumor. You can see it's hot. Okay, that's interesting. So we're gonna look for the explanation for that. Now I can tell you that the other two metrics, DSC and DCE, okay, were both negative for tumor, no support for malignancy, undetectable. So one of the three measures was up, still, let's say, consistent with grade 2, okay? All right, now I'm showing you T2, T2 flare, and T1 with contrast non-enhancing one more time. And now I'm gonna ask you, with all the data that you have, what is your differential diagnosis for this patient? What's your differential? And I'm going to wait. And you cannot say diffuse glioma. We already know that. Thank you very much. I want you to use this to predict. I want you to predict what it's going to be, and you're going to have to weigh the data that you see here. All right. I've got oligodendroglioma. Okay. All right. I'm seeing that. And I like that. That's Octavio RVL. Okay, here's the question. Why would you now there's no T2 flare mismatch. Let's say, here we go. There's no T2 flare mismatch, so it's non-contributory. It does not mean it's an astrocytoma, right? I mean, it does not mean that it's an oligodendroglioma because it's negative for T2 flare mismatch. It's non-contributory. This absolutely could be either one based on that. No, the key here, what is the key? I'm going to ask right now. The key feature that favors is is present on the T2. There's a feature here that favors oligo. Texture. There's a very heterogeneous texture. It's also larger. It's not 6 centimeters, but it approached, I think, 5 centimeters diameter. It's getting close. It's very diffuse. Again, not sharp. Surgery. I said that texture is strongly favored. Okay, you want to see the histology? All right. Here we go. Lower power. There we go. Look at that. Again, classic oligo morphology. One more. Absolutely, based on histology, oligo is way on top, okay? And here we go. We need to explain that arterial spin label, don't we? Yes, we do. Here it is. I think in part, do you see the blood vessels writ large? That's not enough. I wouldn't call that vascular proliferation, but man, I think that's going to increase flow. Absolutely. Those are not the simple, delicate capillaries. Here's another focus of exactly the same thing. This is a grade 2, not a grade 3, but there's vascular alterations. I think that's probably going to be the explanation. That's what I can get. You like that? Okay. Now here's one other thing. Okay. The other thing is microcalcifications here and here. And that also, not pathognomonic, but helps support oligodendroglioma. So here's the final diagnosis. I've redacted, of course, it's outside case. Redacted numbers we always do in this conference. Oligo IDH mutant 1p19q co-deleted. You can see the data there. Now let's look at the comment, and I'm doing this for a reason. H&E stain section showed diffuse glioma with classical morphologic features, oligodendral differentiation, including a monomorphic population of small cells with monotonously surrounded nuclei surrounded by cleared cytoplasm, clear nuclear halos, and scattered microcalcifications. Small foci of microvascular proliferation are present. No necrosis identified. 2 mitoses per 10 high-power fields. It needs to be 6 by the classical literature. French paper, not formally codified in the WHO, but quoted there, mentioned 6 mitoses per 10. It is more or less, might be a cutoff. It's not accepted. Probably doesn't matter again. By report, look at that. Ki-67, 5 to 7. Yeah, up focally up to 20. Again, doesn't matter. We're keeping it low grade. Molecular signature image studies performed by referring institution and a reference laboratory. I've redacted it and shown the diagnosis. Now, here was the point. Listen, here's the point. Neither preoperative MR imaging nor radiology reports are available for review on MD Anderson on our EMR, which we use Epic at the time of the review. Now I use current cases, correct? This was 3 weeks ago. This came through 3 weeks ago. I just showed you preoperative imaging, including ABTI data, right? So did I just borrow that? Did I make it up? No. Well, how did I have it? Okay, 3 weeks ago, I made a note on my calendar. This is my calendar for everything that went on today. I'm a busy guy. And I'm going to get busier because now we only have 1.2 FTE to cover the clinical service. Look at this up here where the purple boxes. These are the notes for today. Actually, this was 3 weeks ago. 3 weeks ago, I made some notes for this Friday for today. Here it is writ large. Check. I've redacted the medical record number. Question: Von Hippel-Lindau. Patient has renal cell carcinoma and ELST. All right. Question about for VHL in progress. I wanted to know what the result was. And I put a note, let's check it because I want to know when to find out. And then look at the second one. Check this number, classic oligo. Question calcification. Now there is calcification histologically. The question calcification was, is calcification visible, present, detectable on the pre-op imaging, right? And so today, sure enough, I went in, the imaging was there, so I could incorporate it into this conference. I thought it was a great example. Now let's go back and look at it. And you can look at the T2, look at the T2 flare, nothing really popping up in terms of calcification, but guess what? We also have susceptibility weighted imaging, all right? And I'm telling you, I don't see it. I think there's not enough. It's tiny. That's okay. Certainly there's no gyroform or curvilinear, and that's fine. Because we know all oligos do not calcify. Obviously, it's nice if you have it, especially the gyroform curvilinear, but you don't always have it. Now, let me ask this, how confident am I that it's really not there? I mean, maybe I'm only showing you one slice, right? But trust me, I went up and down and screened the whole thing. I'm pretty confident. You know why? This is the whole slide imaging, 4 paraffin blocks. Each one of these boxes is the digitized, digital pathology, digitized whole slide imaging of 4 blocks. This was a really nice resection. They got the majority of the tumor out, the bulk of that solid tumor out. I looked at all of this. You see the 2 little black lines? Those are the foci that I just showed you of the microcalcifications. That's all there was in the tissue. It fits with at least no significant calcification on the susceptibility weighted imaging. All right, is that nice? Yes. Okay. Okay, we're going to move on. This conference is working out perfect. It looks like it's 3:53. We're actually going to finish really close to on time. I kind of like it when the conference goes an hour and a half. but today I think we're going to end in about 5 or 10 minutes. This is my last patient. Patient number 3, 10-year-old female. Here we go. All right, Octavio, would you like to unmute and tell us about this? We did that last week. I think I told
Yes,
you.
sir.
Yes. Okay. Go for it.
There is a predominantly cystic mass in the right frontal lobe with a solid component along its anterior and medial margin, and that solid component demonstrates, I would say, avid enhancement. And what is interesting to me is that despite the size of the mass and the enhancing component, there is not a lot of surrounding vasogenic edema, and it's a 10-year-old human being. So I would say that.
Octavio?
Yes, sir.
Yeah, quick question. How do you know it's a human being? That's very interesting that you added that. The only reason why
I use that word because I didn't know, I didn't pay attention whether it was a boy or a girl, but and I think that the shape of the head is pretty familiar to me, and
yeah, okay, I like it. I actually have used animal material in this conference before, so I thought that might be okay. Yes, please continue.
Yeah, so I would say that the top of in my differential diagnosis would be an oligodendroglioma because of the cystic component, and the lack of let's say aggressive imaging features would speak against like a supratentorial ependymoma. But I would bet for an oligodendroglioma first.
Okay, that's good. Look, that's perfect. Okay, let's go because I've got this is going to get more interesting. Thank you, Octavio. Perfect. Now, Octavia, I'm going to ask you not to speak about this next one because it's the crux of the whole thing. But you know, you can feel free to use the chat box, or maybe you shouldn't use the chat box. In fact, I'm probably going to ask all the neuroradiologists and neurology fellows to hold off for a minute on this, and let the neuropathology fellows and all of the neuropathologists and general surgical pathologists who love neuropathology, and that's why they tend try to answer this. I'm going to call this challenge. This is a challenge, and I deliberately saved this case until the end of the conference because I always like to end with something that I think is special. I'm actually going to call this a 401. You know, that's like senior level. So we have kindergarten, 101, 201, 301, 401, and then professorial. I don't think it's quite professorial, but it's, you know, it's maybe graduate student level. All right, listen, here it is. Based on the following images, not based on anything that you've seen. Well, you could use that, but what I want to know, how did the patient fare postoperatively? How did the patient do postoperatively? Based on the following images, understand? And then, well, no, there's another question. There's a follow-up question I'm gonna have, but I'm gonna save it, right? I want you to examine the images. I'm gonna give you plenty of time. And then I would like to, as soon as you have an idea, if you're not a neuroradiologist, let's see some chat as to how you think the patient did, all right? And then you're gonna tell me why, or just anything, okay? All right, let's do it. Okay, and there's no rush here. I'll just fill the time babbling on. I want you to study the images. There has been surgery here. I want you to study them and let me know, just use the chat function, how you think the patient did. Ricardo says that he's had conferences with dog patients. That is super cool. Yeah. Okay, anybody want to weigh in? Octavio says long survival. Interesting. Now I'm going to ask another question. All right. Anybody else want to weigh in? Long survival did well, and a long survival, is this because that's Andrea Gilbert did well? What's your diagnosis, or why are you saying that? Okay, Octavio, I told you not to do that. Everyone will please ignore Octavio's comment. Which specific image? I'm complimenting you, Octavio, but you've destroyed my conference. And Andrea Gilbert's chiming in. Can everyone see this chat? I forbid you to look at the chat. No, it's okay. Hey, when you're brilliant, you're brilliant. Yes. And okay, Andrea Gilbert's already chimed in top left. Which specific image answers the question of how the patient fared? All right, this one. It's the only one that counts. All right. Yes, that. This. All right. How about this? I've windowed it. I've just windowed it a little more. For those, again, who may not know what we're looking at, and kudos to Octavio and Andrea Gilbert, all right, our neuroradiology fellow and neuropathologist, UT San Antonio, Dr. Gilbert, nailed this one. This is a T1 sequence without contrast that shows gadolinium deposition in the cerebellar dentate nuclei. And usually what that means is multiple images, and oftentimes from a while back when we were still using linear non-ionic chelates, gadolinium chelates, which did not have tight binding, like we have today, and you get gadolinium deposition. So here's the bottom line. Which patient populations, listen, which patient populations do we tend to see this phenomenon most often? Obviously, it's those who have had long survival with multiple imaging studies going way back to the earlier agents, all right? And this is going to be neurofibromatosis patients, 1, 2, VHL, other patient population. Or guess what? Guess the latest entry? Guess the latest entry into that? The diffuse glioma, IDH mutant diffuse gliomas. IDH mutant diffuse gliomas. Typically on average for 10, 15 years, 20 years, absolutely. With surveillance, yeah, that's correct. If you hadn't thought about that, it's very real. Okay, here we go. Now, here's the point. Listen, a lot of people attending this conference had to have looked at this, and this is what you saw. You saw this big hypointense lesion there on the bottom too, and you saw the contrast enhancement, all right, around the resection cavity. And what I was going for, I wanted you people to bite on recurrence and not good. Recurrence, not good. And for everyone who did that, you know, what I want to say is, did you even look at that image? Did you even look at it? Did you even give it a passing glance? For many people, I am sure the answer is no. I didn't even look at it. Look, it's tiny. It's like the pathologist that doesn't look at every glass slide because some of them have a tiny piece of tissue. Why not look at a big chunk of tissue that has tumor on it? Am I right? It's human nature, but it's lazy, it's sloppy, and ultimately it will bite you. But it's going to bite your patient worse. And that's what's going to hurt you. That's what's going to hurt you the most. It's not going to be that you made an error. It's that you hurt your patient because you didn't look at the slide with a tiny piece of tissue. You were not thorough. Same thing for of course, for radiology. If you had taken the time to look at that, you would have seen that those dentate are lighting up. Yeah. And it's easy to see if you know what to look for. If you don't know what to look for, you don't have the knowledge base, you'll never see it, right? And that's why we have this conference. That's why we have all the didactic conferences, the ABTI conference, you know, et cetera, right? Yeah, absolutely. There, that was it. Okay, everyone like that? Oh, almost forgot. Would you like to see what the tumor actually is? I don't know. Let's see. Oh, you know, it's 401. Yeah, 401. You know, back in the day when we had this conference at the 16-headed microscope room, we could accommodate we could accommodate maybe 25, maybe 30 people, you know, sitting around. We had the monitors and all that. We had to end at 9. It was 8 a.m. end at 9 because everyone had to get their clinical services. Isn't it wonderful? Yeah, we can go to 4:30. No, we're not going to end. You know, I wouldn't do that. I want to show you. There's another reason why I'm showing you this case. Guess what? It's not an oligodendroglioma. Anybody want to, let's keep the chat open. I'll just do this just for a minute or so. It's not an oligodendroglioma. Anyone want to take a guess as to what this tumor is going to be? And then I'm going to show you the histology, the final diagnosis, and I will also give you the follow-up. So you will own the complete case. Okay, I've got pilocytic astrocytoma. I like that. Large cyst with enhancing mural component. I'm not going to call it a nodule. It was a component. I've got PXA. Okay, very, very good. Pleomorphic xanthoastrocytoma, also frequent large cyst with an enhancing mural component. Ependymomas can look like this. Ganglioglioma, Dr. Gilbert, absolutely, ganglioglioma. Dr. Ribalta, it is an honor, Dr. Ribalta, to have you present at this conference. This is Dr. Teresa Ribalta, one of the most experienced oncologic neuropathologists in Europe, in Barcelona. Okay, all right, that's good. No one has the answer yet. Astroblastoma, I just said that. No, not astroblastoma either. Supratentorial hemangioblastoma, Dr. Perez, our current neuropathology fellow, now rotating MD Anderson. Really good thinking about that. We know that supratentorial hemangioblastoma, it's the rarest location and usually occurs with von Hippel-Lindau. And if this was von Hippel-Lindau, that would fit in with the gadolinium deposition, wouldn't it? The negatives for von Hippel-Lindau would be the cerebellum is clean, the brainstem is clean, no hemangioblastomas, et cetera, and yet all of this obvious surveillance imaging. But sporadic supratentorial hemangioblastoma, it has to be in your differential. Good job. Anybody have any other guesses? No one said what it is yet. I haven't heard it. Okay. I kind of have heard it, but not quite. Okay. Dr. Gilbert and Dr. Ribalta. Actually, I'm going to go ahead. They said ganglioglioma. I'm actually going to give you full credit. Great job. All right, here we go. Low power, higher power, higher power. What's interesting? Anybody see an interesting cell? That's a binucleate ganglion cell. These are all ganglion cells. They are all, let me repeat that, they're all ganglion cells. What's the diagnosis? Okay, I'll keep showing histology so until someone tells me what. Yes, Dr. Gilbert, got it. Look at that. More binucleate and multinucleate. Yes, Dr. Perez got it right. Dr. Harb got it right. Dr. Gilbert got it right. This was called ganglioglioma. Its behavior is absolutely gangliocytoma. Back in the day, when I was Peter Berger's fellow, we would often use ganglion cell tumor when it was indeterminate. I'm telling you, this one is really good in the histology for gangliocytoma. Ki-67, almost zero. I mean, maybe one label nucleus, that's it. Doptro grade 1, and listen to this. Here's the follow-up. Post-surgery residual contrast enhancing tumor has been stable with no change for 10 years. So this tumor that you're seeing there, this resection was done on the outside. This was not done at MD Anderson Cancer Center, all right? The patient came to us for a second opinion on treatment. This case, I checked the notes. I checked the notes of this case, and at tumor board, the case was presented at tumor board. Seeing this as the post-surgery result plus the histology, and the decision said that we will surveillance imaging to start at every 3 to 6 months, increase to a year, and after a decade, for a decade, and then at a decade can consider going to 1.5 to 2 years, that sort of thing. Guess what? What you're looking at is the latest imaging follow-up, and the conclusion was no change in residual enhancing component. That's exactly what it looked like before. It's what it looked like on the immediate post-operative scanning a decade ago. She's good to go. In fact, now at a decade and a half, I haven't seen it. Maybe the follow-up will be in 1.5 or 2 years. A huge success story. Did you like that? I'm sure for many people, this is probably your first gangliocytoma. Gangliocytoma, it's all ganglion cells. There is no convincing glioma component. You know, they can be pleomorphic. They usually look like pilocytic astrocytoma in the background. There's usually EGBs, usually granular bodies. None of that here. It's basically neuropil, and these atypical ganglion cells. How gorgeous is that? Gangliocytoma. All right. Yeah. So that's what's happened. Okay. What's going to happen to the conference? I don't know. I tell you what you can do, if you would like to just shoot me an email, you want to vote, let me know what to do. This is really a hard one. We got to go either super early, you know, at Central Standard Time, United States, Texas, Chicago, or weekend. I'm thinking for many people, weekend might be best. I'm honestly thinking maybe Sunday evening or early Sunday morning. You know, if you got religious services, you know, you go to late mass, you do what, you know, I don't know. It's a tough one. All right, so you can vote, but we will get through this. And I want to thank everyone for coming, for attending. There's no conference without you, and I will find a way to keep it going. If you vote, listen, if you vote for early morning during the week, maybe Friday, keep it Friday, knowing it's Central Standard Time, you can vote for 5 a.m., 6 a.m. I think it's got to be 5 or 6 because in the conferences, or maybe I can find a day where it starts at 7. Okay, with that, I'm going to end the conference and thank everyone for attending. Much appreciated. I'll send you an update.